Good afternoon, everyone. It is a pleasure for me to present here. My name is Zsombor Matics, and my PhD topic is infections in fibrosing interstitial lung diseases. I work in the Department of Pulmonology in the Semmelweis University, and I am an internal medicine specialist, and my second specialty will be infectology, because I'm interested in infectious diseases. That's why I have a vision that infectology will be an inseparable part of the evaluation of interstitial lung diseases. And I have a team supervised by Veronika Müller and Gábor Horváth, and we have a mission to provide evidence-based data that draws attention to the importance of infectology. And we also have a very good scientific methodology supervisor called Chener to run. I have two projects ongoing. My first one was started in September of 2023, and it's called Comparing the Effect of Antifibrotic Treatment on the Incidence of Respiratory Tract Infection in Idiopathic Pulmonary Fibrosis. It's a systematic review and a meta-analysis, and I plan to submit it in a year. The problem with idiopathic pulmonary fibrosis is that the disease is rare, but a deadly disease with a poor prognosis. The median survival is 3 to 5 years. And the best treatment we can give to the patients are antifibrotic drugs. These are standard of care now, but they can only slow down the progression. And we know that antifibrotics reduce the investigator-reported acute exacerbations and mortality as well. And behind this high mortality, acute exacerbations are the main reason. Acute exacerbation is the #1 killer in idiopathic pulmonary fibrosis, and it can be triggered by many things like pollutions, drug toxicity, aspiration, lung injury, but the most important is infection. It is the most important because we can impact the number of infections, and reducing the numbers of infections, the incidence of infections, are the most important things in preventing the evaluation of the pathogenesis of chronic lung diseases and preventing acute exacerbation of IPF as well. So we know that antifibrotics reduce the occurrence of acute exacerbations, but we don't know if any antifibrotics reduce the incidence of respiratory tract infections as well. So our aim is to investigate the effects of different antifibrotic treatments on IPF of the incidence of respiratory tract infection. Our clinical question is, does any antifibrotic drug reduce the incidence of respiratory tract infections in idiopathic pulmonary fibrosis? Our population of interest is patients with IPF. Our exposure group is patients treated with antifibrotics. The comparator group is without the antifibrotic treatments or treated with placebo. And our outcome is the incidence of respiratory tract infection. And our hypothesis is some antifibrotic treatment in IPF reduce the incidence of respiratory tract infections in idiopathic pulmonary fibrosis. And it is very important because if there is a correlation, then we can rank the available antifibrotics on the effect of treatable threats, such as respiratory tract infections. So I did a systematic search, and with this search key, I could find more than 10,000 articles. And here you can see my first 5 key articles. These are all multi-center double-blind placebo-controlled randomized control trials with at least 52 weeks of duration period. And you can see my flowchart selection here. With my search key, almost 20,000 articles could be found. After the duplication removal, more than 10,000 articles remained. And after the title abstract selection, more than 900 articles left. And my full text selection is under evaluation. And here I want to thank for Anna Barlóci and Csongor Galko for the title abstract selection and the co-investigatorship. So my first topic is feasible. My Prospero was registered. My duplication was removed. My title abstract selection is completed, and my full text selection is almost completed. I am at 85% now. My second topic, called comparing the effect of different immunosuppressive treatments on the incidence of infections in scleroderma-related interstitial lung disease. And it is also a systematic review and a meta-analysis, and I plan to submit it until November of 2024. The problem is interstitial lung disease is one of the major forms of lung involvement in patients with systemic sclerosis limiting survival. The prevalence of interstitial lung disease approaches 50% in patients with diffuse cutaneous systemic sclerosis. So we know that the ILD in systemic sclerosis patients plays an essential role to death, and we can reduce the incidence of ILD by treating the patients with immunosuppressant drugs. But it is a risky treatment because they are increased risk of infections, which also leads to death. So our clinical question, is there any immunosuppressive therapy that reduces the incidence of infections compared to others? So our population of interest is patients with SSc-ILD. Our factor, which we want to compare, is the immunosuppressive therapy, and the outcome is the incidence of any infection. And our hypothesis is some immunosuppressive treatment comes with reduced incidence of infection in scleroderma-associated interstitial lung disease. And it is very important because if it comes that there is an immunosuppressant, then we can rank the available immunosuppressive treatments based on their effects on treatable threats, such as infections. Here you can see my first 3 key articles. These are all randomized control trials, and all of the articles contain the necessary outcome parameters to make another systematic review and a meta-analysis. And to summarize, I have 2 projects ongoing. Both of them are systematic review and a meta-analysis, and I plan to submit them until the November of 2024. And I want to thank you for your attention with the words of Seth Godin. Everybody has their own Mount Everest. They were put on this earth to climb. Thank you very much.
Congratulations to your great presentation. I would like to ask you regarding your first project, who is deciding if the patient gets the antifibrotic treatment or the non, and on what kind of basis is this decision made?
Yeah, antifibrotics is a standard of care now, but in previous studies, in advanced idiopathic pulmonary fibrosis, patients with advanced idiopathic pulmonary fibrosis, they were excluded from the studies, but now they are standard of care.
Okay, thank you.
I'm very happy to help you with your project,
Thank you very much.
It's wonderful. I have one question. In Hungary, how many patients dealing with systemic sclerosis?
There is about 10,000 people in Hungary affected by scleroderma. Yeah.
Thank you.
My congratulations, a very nice presentation. I would like to ask about the infection, because you didn't mention any specific bacteria or something, so it's like community-acquired infection typical or some specific variant? Thank you.
Yeah, thank you very much. Actually, it is a very good question, I think. I think this is one of the highest limitation of the randomized control trial I just searched, because there are no data about the specific pathogens in the randomized control trials, and they are reported as adverse events, and they are diagnosed by clinical signs, and for example, pneumonia, by the sputum and by the chest X-ray, but they don't report the exact pathogens. Thank you very much.
Congratulations, nice presentation. I have one question. You're saying that you would like to rank the antifibrotic drugs, but how many antifibrotics are available in Hungary or in the world?
Today, there are 2, nintedanib and pirfenidone, and compared to each other, there is no superiority between them. but we want to find out if there is a superiority based on the effect of infections.
I also have a question to your second project, because you are testing several immunosuppressants, okay? And you want to rank them in the aspect of infection. Now, the key articles you showed, they all compare the immunosuppressant drugs to placebo.
No.
No?
No.
Then, because there were 3 articles you showed, and 2 of them compared them to placebo. So the third one I had no time to check then.
Yes.
Okay, but anyway, how will you be able to use those articles in which there is a placebo group and not one drug is compared to the other?
Yeah, we were talking about this with the statisticians, and it is available by an indirect comparison. Yeah.
Because if the population is more or less the same, then you may. That's good.
So I would like to ask one question. How is it possible that the immunosuppressant treatment leads to a lower rate of infection?
I'm sorry.
How is it possible that the immunosuppressant treatment leads to a lower rate of infection than placebo? Because that was what I figured out from your presentation.
We want to find out if there is an immunosuppressive treatment which comes with a reduced incidence compared to each other. So we suspect that all of the immunosuppressants comes with an increased risk, but compared to each other, maybe cyclophosphamide comes with a reduced incidence.
Okay, I think that was missing for me. Perhaps I didn't check it.